Thank you for staying with us. I want to present our study on the prognostic impact of TAPSE-PASP ratio in patients with acute pulmonary embolism. Currently available risk stratification models for acute PE include biomarkers, RV dysfunctional imaging of tomography and echocardiography, and clinical scores such as PASE score. In this study, we wanted to assess the predictive capability of TAPSE-PASP ratio and the comparison of this ratio with TAPSE or PASP values alone. Compare TAPSE or PASP as distinct measures. And we evaluated more than 700 patients referred to our center. We divided patients by TAPSE-PASP quantiles, and we created 3 different models. We used PASE score and right ventricle to left ventricle ratio as a base model, and then we added TAPSE, PASP, and those ratios separately to compare the predictive value of 3 different models. On this panel here, on the left-hand side, we see that TAPSE-PASP ratio decreases as the risk status increases, and on the right-hand side, similarly, TAPSE-PASP ratio decreases as the simplified PASE score increases. On this plot here, we see our 3 different models. Base model, which included PASE score and RV-LV ratio for adjustments, and we add TAPSE, PASP, and the ratio separately. The purple line represents the model with TAPSE, PASP ratio, and it provides the highest accuracy, highest predictive capability compared with other models. We also defined a cutoff value to predict in-hospital mortality using TAPSE, PASP ratio, and the value is defined as 0.34. In conclusion, the outcomes of our study reveals that the ratio of TAPSE-PASP serves as a more potent predictor of in-hospital mortality than either of the 2 measurements taken separately. And the interpretation and utilization of this ratio and this cutoff value in acute PE can guide risk-based treatments across all the risk groups.
Thank you.
Thank you.
Any question? Any question? Okay.
It's very clever observation also because it represents how right ventricle cope to the increase of afterwards. Do you think that there are some conditions where it's more useful? I mean, for example, a patient at intermediate risk, because we know what to do in low risk, we know what to do in high risk. Intermediate risk are still patients when there are some controversial issues. Do you think that these patients should be better, should work more?
Well, for this statistical model, we included risk status and RV-LV ratio to adjust for those variables. That means an increase or decrease in TAPSE-PASP ratio in the same risk groups. In the same risk group means a higher risk of mortality. For instance, in a patient who is at intermediate risk, a decrease in TAPSE-PASP ratio is valuable compared with the same patients in the same risk group.